Welcome back once again. We are going to on round three, third episode of our talking about the paradigm of long COVID, and we're going to talk about just a lot of the therapeutics. Many of these people have heard of, some they haven't heard of. These are all, not all, many of them are repurposed medications, some are repurposed herbal things. Many of them work for many different things. They don't just do one thing; they do multiple things. And so a lot of times we have to like layer things and use things that make the most sense for the individual. But this is just to give people an idea what some things are out there
Yeah.
that we've had really good success with. We're going to start with like one-offs, like things we've done, like that we did this one thing. Oh my gosh, that worked so well.
Yeah.
And then go to some of the more esoteric things. I don't know if you have any introductory remarks.
No, I think it's basically, we talked about the issues with the government kind of essentially saying we're done and how patients are kind of left in the lost in the shuffle. And then we last time we discussed the pathophysiology, or at least proposed mechanisms. So I think now it's time to give some people actionable options. And so we'll run a list and we'll talk about what these things are, what they do, what our personal experience is, and then our advice would be to do your own research and then speak to your providers about it and see what might be indicated for your specific case if this is something that you think is going on. And worst case scenario is they say no, but at least you tried, and then you can maybe move on to the next person. But you shouldn't just sit thinking that you don't have any options and that you just, are destined to a life of suffering. That's not okay. So I think for me, probably the biggest game changer is most likely low-dose naltrexone. I mean, like, that's probably why it's at the top of the list.
Number one.
Number one. So low-dose naltrexone is an opiate antagonist. And it was studied back in the day for the opiate epidemic that was going on as a way to intervene in a non-opiate based mechanism of action, meaning help people control their pain without becoming addicted to pain medicine. And in studying it and seeing the benefits of it, they realized that there was this kind of paradoxical effect that wasn't expected, where you saw this kind of upregulation of opiate receptors and upregulation of your own endorphin production, so your own natural pain medicine, and then this concomitant anti-inflammatory, anti-neuroinflammatory, immune modulatory effect that was just kind of like, wait, what? What just happened? And it's just snowballed, and now it's just being used almost ubiquitously. I mean, I use it in
Yeah.
chronic fatigue, fibromyalgia, other chronic pain syndromes, long COVID, SIRS, and biotoxin illness, all of my autoimmune cases. I have some people with mood disorders that I use it for. It helps suppress your appetite, and I have some people that have issues with addiction that it can help. I mean, it's just one of these things where it's just almost become like a panacea, and it's because it's this kind of subtle underpinning of regulating the system in a more balanced way. And it's not always a hammer over the head. It's not always this kind of night and day, oh, I'm on it. Now all of a sudden everything's all better. A lot of times it's, how do I know it's working? And my answer is always, let's stop and see. And 2 weeks later, like clockwork, hey, can I get back on my LDN? Yeah,
Yeah.
you can. My sleep's off, my energy's off, my pain's back. I guess it was working. But I do have these cases where it's been like, oh my God, I'm back. I'm better. It's all normal again. I feel great. Can I be on this forever? So it's one of these things where I think for me, that's by far been the biggest hitter. What about you?
Well, what's the most you do use with low-dose naltrexone? Your highest dose of
I do up to 4.5 milligrams. I know you do
milligrams?
some higher dosing than that. And sometimes you do some BID dosing. I'm pretty standard. I go 1.5 milligrams nightly for about a week, and then you go to 3 milligrams for a week,
Yeah.
and then you go to 4.5 milligrams. If they're on it chronically, and chronically depends on the individual, let's just say greater than 12 months, I have them then start dropping a few days, where just to kind of keep the receptors sharp and prevent tachyphylaxis. So the first 3 of the last 3 days of the month, they might stop it and then you just get right back on it. Some patients don't get up to 4.5. They don't tolerate it. They feel better at 3. Some feel better at 2. I have some that feel better at 0.5. I don't really go much higher than 4.5, although I've had a few patients do that on their own, unbeknownst to me, and then just be like, "Hey, oh, by the way, I've been taking 9 milligrams and I feel amazing." I don't see any recourse clinically. I don't see anything in their objective data that says it's hurting them, so I let them stay there, but that's not really where I'd go right off the bat. What about you?
Well, there are some practitioners that are doing like microdosing of like point 0.5 pills and point 0.5 to 1 to 1.5 to
Yeah, I've
2.
done some of that
And
too.
that's some of our super sensitive
Yep,
patients.
yep.
I've had a few patients who couldn't tolerate my mouth and did topical cream. That
Awesome.
worked awesome for
I
them,
use
yeah.
that for skin and for rosacea. It works really great for that. Rosacea and, sometimes eczema and psoriasis.
Also works great if someone's had, cosmetic surgery to decrease scarring.
Yeah.
So breast
Yeah,
surgery,
yeah.
put on the spot, it works
I
great for.
used it on a keloid in a
Yep,
patient and it
yeah,
helped. Yeah.
yep. Um, but the FDA has approved naltrexone for weight loss, and the doses for that are 8 to 16 milligrams twice a day. So some of my patients who, want weight loss stuff and have some other things going on, who've had some benefit, I will, in some select patients, do a trial. Let's try 4.5 twice a day. Let's try 9 once a day. Let's try 9 twice a day. And I basically will bump them up. And if they feel better, we'll stick there. Um,
That's
I
cool. I
probably
like
had
that.
30 or 40% of people. The what now? This is me self-selecting based on my clinical expertise and a bunch of other stuff.
Yeah.
So I'm not just really nilly doing it. But I had some patients who respond nicely to like, and sometimes it's 9 milligrams, and sometimes it's 9 milligrams in the morning, right? But I've had a subset. It tends to be my POTS dysautonomia, um, my chronic fatigue-ish hypermobile patients, who that little extra works better for.
Yeah, great.
But it's like a therapeutic trial, and it's pretty safe. What's the downside? And the FDA has approved the dosing.
Yeah. I don't
So,
see many side effects, if at all. I mean, like, if anything, and this is reported in the literature, and I've seen this clinically, vivid dreams, like sleep disruption and vivid dreams, it's typically transient. If it persists, we go down on the dose, it goes away. I had one patient with a little bit of dizziness. It was dose dependent. One patient with some appetite suppression. I think that's the point. That's what you were just talking
yeah.
about. And one patient who had somnolence, and so, they felt like it made him too tired, and so we went down on the dose and it got better. Like, none of
Yeah.
them had to stop because of these mild side effects, and I had no one have a bad outcome
Yeah.
from it.
And I've got one person who taking it in the morning gives them energy all day long.
Yeah,
And I have people who take it at night and it helps them sleep like a
a
baby.
and
It's
and the coolest thing, my favorite thing is, like, I get somebody who's got an autoimmune disease, and they're being told that there's nothing we can do other than manage your symptoms, or they're put on a DMARD, some immune modulator or something like that, and, I work on their gut, I get them gluten-free, maybe dairy-free also, I put them on LDN, and I just watch the anti-TPO antibodies and the
yeah.
rheumatoid factor and anti-CCP, I just watch them going down, it's, like, my favorite thing. "Oh, you're heading towards remission." It's like it's just pretty profound what it does. Alright,
So,
what else on this list?
um,
Big hitters.
GLP-1s,
Yeah,
particularly tirzepatide,
yeah.
particularly microdosing.
Yeah, I use those a lot. I haven't used them in long COVID a lot. So give me some of your long COVID experience with GLP-1s.
Okay, so someone who's had long COVID who's reactive to stuff, like, I can't do that. I'm reacting to everything. Like, I rash up. My wife is a great example who, like, gets exposed to stuff. She'll get hives, get tingling in her mouth sometimes. 100% gone with microdose of GLP-1. Um, your dysautonomic patients who have their nervous system hyperreactive, and you're like, this sounds mast cellish, and they're having some dermal things rashing, and they just are super reactive to their environment. That's like the subset that I found the GLP-1s to work really well with. And how I know they have an inflammatory component is because when I start their microdosing, which is for me, I usually do like 1/5. So it's like 0.5 milligrams, not 2.5 milligrams.
Yeah.
They lose 5 to 10 pounds.
Yeah.
And all of a sudden, that's not the weight loss, that's the anti-inflammatory.
Yeah.
And I've had several of my really super reactive people lose like 5 to 10 pounds on a microdose. And you're like, okay, that's pretty cool.
Yeah.
And it's really funny. When I first started using these drugs, 20 years ago, it was like all my diabetics, and I was giving them super crazy high doses of stuff with Byetta, then Victoza. And now I'm doing like 80% of what I do now is microdosing,
Yeah.
or
Where are you
super low
starting for
doses.
semaglutide? Point 1, point 2,
For semaglutide, well, the like FDA starting dose is 0.25.
point 0.25. So
So
I usually start at like point 0.1.
I, I used to start, I usually do a fifth of that. So instead of the 0.25, I just calculate that dose and just
So you're
divide.
doing 0.05.
Yeah,
Yeah.
yeah,
Even lower.
yeah. And again, I'm almost now I'm mostly using tirzepatide. I've had less side effects with it.
Yeah. Same.
It's a little stronger.
Yeah.
Um,
It's a twofer. It's two peptides
yeah, and then we got retatrutide, which is.
in the pipeline.
Yeah, and, I've only had 1 or 2 people use it with really bad outcomes actually, so, I'm just waiting to see what happens with that one,
Yeah.
because I've
Tirzepatide's probably my
it
go-to.
is mine as well, yeah.
Yeah.
It works well. But GLP-1s, do you have another, like, one you've used with people who are like, "Oh my gosh, this is, like, I wanna start with all, like, like, you've done one thing and people feel amazing because we don't have time to go through everything,
Yeah,
but
yeah. I would say all the mast cell stuff, and, like, that's not a one thing,
well, okay.
that's a
So
stack.
let's because that is a stack. So, cromolyn.
Yeah,
I've had literally had a particular patient who had POTS and dysautonomia and horrible pain, and the oral cromolyn made it all go away,
yeah.
and it was just like,
That's profound. Cromlin for me, it's like that, and that's th that it's the rare case where you get that. More often than not, with Cromlin, it's like I don't notice a difference, but if you get that one magic case where it's like, no one's tried that yet, and you give it to them, and everything gets better, that's pretty profound, and I've had a few of those. Ketotifen has kinda been that for
oh, yeah,
me
yeah.
because they're like, "I try the over-the-counter antihistamines, but I don't like that they have other stuff in them, and then I take them for a time, and they wear off, and then I take something else, and then that works, and then that wears off. And I don't wanna suppress my stomach acid with Pepcid because I know that that's bad for my microbiome and my digestion and et cetera, et cetera." I'm like, "Well, what about ketotifen?" And ketotifen, you can get it compounded, and it's a combination mast cell stabilizer and antihistamine. So
So
it's up and downstream. The only main issue is that it's centrally acting, so it can be a little sedating. So I go low and slow with the dose, maybe 0.51 milligrams, something like that, and I have them start at night. And if they take it at night and they sleep fine through the night and they're not somnolent the next morning, they're not dragging, and they do fine throughout the day, we just do it at night. But you could also do BID dosing, and you could do higher dosing than that. But it's profound. I take it. My wife is on it. My daughter's on it. It's been a game changer for all three of us and our allergies and our mast cell issues. And so I think ketotifen is a really, really profound one that's impacted a lot of my long COVID patients that also had a concomitant mast cell presentation picture. What else?
cyclobenzaprine. Cyclobenzaprine now at the 2.8 milligram sublingual dose is FDA approved to treat fibromyalgia. Hmm, interesting, interesting.
Yeah,
And so cyclobenzaprine, and it comes as a 5 and 10 milligram pill, and I'll usually take the 5 and break it in half.
yeah,
Unfortunately, the 2.5 2.8 sublingual is not it's expensive, and insurance doesn't like paying for it.
yeah,
But it's interesting because people think about it as a muscle relaxer, but also as a mast cell stabilizer. It also has some, cholinergic effects, and it can be really helpful if people are having sleep disturbances. You just if you wanna stick it on your tongue, it's nasty, or just swallow it. I've had some people do really well with that. Um, Clonidine and guanfacine, particularly if the person's having a lot of POTS dysautonomia patient symptoms, particularly waking up in the middle of the night, your heart is racing, symptoms that sound like adrenaline surges in the
yeah,
middle of the night, right?
yeah,
You go horizontal, and all of a sudden, for some reason, epineurepy goes crazy. The clonidine and or guanfacine, I'll play with that depending on which the person, it can be super helpful if their long COVID is having, like, the POTS kind of type symptoms. Some people just can work really, really, really well, and, if someone's having some pain issues with their long COVID and, um, sleep disturbances and, like, this anxiety, like, issue, we've tried a lot of things, low doses of benzos, which I was trained to avoid, da, da, da. I've had some people do really well, and I know it's a mast cell issue, and literally you're taking your, um, small, Xanax or Lorazepam, and you quarter it, and you take it, and you're like, "Oh my gosh, I feel so good."
yeah.
Like that I know this is a mast cell thing.
I'm wondering if have you ever tried L-theanine in those patients? I'm wondering if L-theanine, which is a basic amino acid that I
Yeah,
use, it's an adaptogen. It's basically an anxiolytic, doesn't have addictive potential. I would put it in the water if I
oof.
could. It acts like a low-dose benzo because it works on GABA receptors and it works on actually dopamine receptors as well. I'm wondering if in some of those cases where you're maybe going to reach for that really
Yeah.
ultra low-dose benzo that you try some L-theanine and see.
That is, not my first, second, or third thing, it's a thing that can be really,
Yeah.
like, oh, kind of, like, amazing.
Yeah, yeah,
If you're coming with sleep disturbances, there's actually a product called 200 milligrams of Zen,
yeah.
which is theanine plus 5-HT and a little bit of GABA, and that I typically use that in my patients who have, like, the mind racing, like, you're in
Yeah,
bed, and
yeah.
you're kinda stuff.
Yeah, yeah.
They can be really great for that.
Yeah, it's the, Magnolia and, Hinokiol is really great for that
Yes.
too.
Yeah,
So,
yeah.
yeah, those extracts are great for
That's
kind of
right,
calming that mind.
it's Relora.
Mhm.
Yeah, yeah.
Mhm.
So, other something else you've used that literally before and after, people are like, "That works so well with me."
Depending on the case, but and this isn't for all these cases, but in certain situations, it's a game changer. Um, antivirals, in particular, antihepatic virals, like the valcyclovirs of the world. If I have someone who is really screaming reactivation, EBV reactivation, high CMV titers, high HHV6, I may start with like lysine. I may sprinkle in some olive leaf extract or monolaurin and go the natural route. And eventually they're like, I'm not really feeling any different. I'm like, all right, well, let's kitchen sink it. And we do a course of Valtrex. And I don't mean like 7 days. I mean like 30 days or 2 months. And they come back and they're like, my brain fog's gone and my energy's back. I know that that was an intervention that made a difference. And I track the numbers and you can see these titers get better. You still got to globally work on the system and get the T cell polarization that led to the unleashing of these latent viruses back balanced, but it can really hold space for you in some of these situations. You just got to be mindful of some of the side effects that go along with chronic
What
use.
what dose are you using for the Valtrex?
Typically a gram once to twice a day.
Course, yeah.
Yeah.
Yeah, some of those people, when they come back, I'll do, like, a gram 3 times a day and do
Yeah.
have, like, 1 to
Hit them
2
hard and
max.
then
Yeah,
de-escalate.
yeah,
Yeah, do the
yeah.
same. Yeah.
So, anything else we have a list of a lot of things, but things that you've used in your clinic that you people have been like, "Wow, I did this one thing and I felt like," I don't wanna say that, "Oh, that was the one thing,"
Yeah.
but I wanna give people a list of things that we've done that have been, like, literally pretty cool.
Yeah, those were the big ones. I think like from a supplement standpoint, with some of the respiratory issues, in particular, I air hunger. I've had the workup. My D dimer is like marginal. If someone did a PECT or DVT studies and they're negative, and I've seen a pulmonologist and my pulmonary function tests are normal, and the cardiologist signed off. Why can't I breathe? At that point in time, especially if their fibrinogen is elevated, I give them some nattokinase. I give them some NAC. The combination of those, maybe bromelain, maybe quercetin, and all of a sudden their breathing is better. I think that's pretty profound. And those are all supplements. I mean, natto literally comes from fermented soybeans, and ultimately NAC to me is like something that everybody should just be taking on a daily basis. It just does everything good for the body. Um, this is newer in our practice, and you alluded to this. I think we should dive a little bit deeper, but some of the phospholipid work. I mean, why don't you touch in on some of that, some of the IVPC? I mean, you've had patients that I think that one patient that couldn't breathe, seeing everybody, and all of a sudden you do a couple IVPC infusions and she's breathing better. Like that probably was not a coincidence.
Yeah, so, you know, what's the one ring that rules them all, right?
Yeah,
Everybody wants the one party trick that does everything, right? And stepping back, it's like we say mitochondria, we say gut, we say vitamin D, whatever. And really, the cell membrane, the cell wall, everything is stuck in a phospholipid bilayer.
yeah. Cell and mitochondrial membranes, right? Yeah,
100%, yeah. Um, a lot of things we do for, making more bile, omega-3s, omega-6s, phospholipids, butyrate, TUDCA, ursodiol. They were using ursodiol early on in China to treat long COVID. What is ursodiol? It's a prescription version of TUDCA, torsodeoxycholic acid. It's ursodeoxycholic
yeah.
acid.
It's the secondary
It's
bile.
UDCA, not
Yeah,
TUDCA, right?
yeah.
And, strangely enough, they are using it now in liver patients with primary biliary cirrhosis, post-transplant patients to bring the liver enzyme levels down. There's now research on it with our NASH. I'm sorry, NASH no longer
Maffle
exists.
D.
Yeah, MAFLD,
Yeah,
oh my gosh,
yeah.
metabolic associated fatty liver disease, right? To help bring down liver enzymes. I've actually had patients using the combination of TUCA and or yosodiol with butyrate and PC have mid to high range, their F scores on their, there's a special ultrasound you can get that shows the stretchiness,
Yeah,
last called
elastigраф.
yeah, yeah, have that normalize over a year. One of my patients actually went up to the NIH, and she was trying to get a study up there, and, she failed because her numbers actually started getting better because she was working with me, so they didn't
Yeah,
let it get her in the study.
yeah, awesome.
Yeah, I know, so, and even GLP-1s in those
I
patients now.
reversed fatty liver in 2 patients with
Yeah,
tirzepatide.
yeah, and so we're kinda coming back to cell membrane stuff, and so, how many of your patients do you start on oral phospholipids and the brain fog gets better?
Yeah,
It happens, so in lipid medicine, we say phosphatidylcholine, sure, check. We'll mention that we give lip service to balanced omega-3s, omega-6s, and the doses are a tablespoon to 2 tablespoons once to twice a day, so these are elevated doses,
yeah.
And people,
It's an oil change.
oil change, and you can't do it with like a capsule or 2
Yeah,
capsules. You gotta get you need the
You
scoops, which
gotta
is
commit. If you're gonna do it orally, it's a commitment.
and then add
IV is a commitment too,
yeah.
financially and logistically, but that's the bang for buck. I mean, that's where you're gonna see the most headway, and again, as he was mentioning, all of our cell membranes, that's where all the action's at, right? It's where the cell itself is regulating, it's where the cell is communicating, it's where the cell is defending, it's where the cell is doing all the things that are necessary for it to be a cell and function. The mitochondrial membrane's on the inside of the cell, but serves the same purpose, maybe even more important. And it's a lipid bilayer, so it's 2 layers, and it's supposed to be that way, and it's supposed to be very fluid, and they're supposed to be able to kind of move across and around each other. And over time, as they get dysfunctional and toxic, these lipid rafts that he had mentioned previously form, and cause that lipid membrane to be less fluid. And now it's stuck, and now it doesn't work as well. And now the cell doesn't work as well. And now the mitochondria don't work as well, and you don't work as well. And so it's like in your car, over time, the oil gets rancid and turbid, and you have to go to the mechanic and get your oil changed. This is you getting an oil change. So it's cholesterol in the cell membrane, it's omega-3s in the cell membrane, it's omega 6s, and it's these phospholipids, which are the unsung hero that no one talks about. And so you get your 3s, you get your 6s, they have to be quality 6s, and there has to be balance, and there has to be a proper ratio, and cholesterol that's been demonized and suppressed by statin use, all these things that are going wrong already. Again, phospholipids, it's PC, which is phosphatidylcholine, and then it's phosphatidylinositol, phosphatidylethanolamine. It's multiple phospholipids. And as you're putting them back into the system, you're changing out the bad fats, you're putting in the good ones. These lipid rafts or very long chain fatty acids get burned out by the TUDCA and the butyrate. You're detoxing, you're getting it out, and things just work better. People just feel better. You can use it for renal vascular disease. You can use it for central nervous system issues. I do it in my SIRS patients. I'm doing it in a cardiac patient. I'm doing it in a renal patient. I'm doing it in a Parkinson's patient. And these are things that I think are potentially game changers. And if you do the oral route, it's a commitment, but it should be done in just about every SIRS patient, in my
and
opinion. It should
and
be part of the Shoemaker protocol, as far as I'm concerned.
it's a part of Dr.
It's part
Hay
of the Heyman protocol.
yes, it is, yeah. So we've been doing it for a while.
Yeah.
But one of the things of interesting, if you do IV phosphatidylcholine, the IV form actually is a slight blood thinner. So people, if they have any, I've noticed more of my older people, like 70s-ish, they'll be like, "I'm thinking better, have more energy, I'm sleeping better," because 'cause you're getting an immediate blood thinning,
Yeah, they're
mild,
perfusing better, yeah.
infusing better. And then when you're doing IV, that's the way you actually get when people have endothelial dysfunction and they start getting thickening of the cell, the vascular wall, the tunica media. I'm trying to use simple words here.
Yeah,
Um, that you actually start pulling that out. It's like soap pulling this stuff out.
yeah,
And oh by the way, it's stabilizing cell membranes and walls, so the mast cell stuff gets a little better.
yeah,
Oh, by the way, these lipid raft things are becoming unlipid rafted, and which part of that is how infections will bypass your immune system and jump from cell to cell to cell, which is why some people will get chronic Lyme and Epstein-Barr. We can't get them away because their cell membranes are so wrecked.
yeah,
Now you're rehabilitating those cell membranes. Now maybe your antivirals will work. Maybe now you won't need them because the immune system can work more appropriately. So they can be really helpful.
yeah,
And oh, by the way, some of the stuff with you talk about viral particles and vaccine particles and, or toxins, what is the soap for that stuff to get it out? IVPC.
yeah,
So all of a sudden, like if this person has issues not getting better, now IVPC is tricky, is only like one, maybe two places in the world you can source it from. Um, you gotta do it a certain way. You gotta, wrap the bag in aluminum foil. You cannot put it in normal saline, which I've had patients go other places and do that, which I'm like, "Oh my gosh, that's how you, like, clot people up."
yeah.
Um,
It's gotta be a slow
it's gotta
infusion,
be
it's gotta
slow,
be
it's gotta
monitored.
be D5. So it's
You gotta
something that's
stack it with other things,
yes.
usually B12, glutathione, leucovorin.
Yeah. And if you're getting really fancy, you might even use a little, phenylbutyrate,
Yeah,
sodium phenylbutyrate in the front
yeah,
end of everything. But the point is, like, this can be super helpful, and my daughter Anna did just about 30 of them, and for her, she, people know my story, I'm not gonna go in detail with that, but, a lot of issues with her, but she improved fine motor function. Now she's actually when she draws, she colors within all the lines now, and, as of 2 months ago, she was able to see stars. She's like, "Hey, dad, I'm seeing stars." I'm like, "Well, what
Did
do
you
you
hit your head?
did we do?" No, she's like, "Have you never seen this before?" She's like, "No, I can see them now."
looking up at the sky.
Yeah.
Oh, that's
I'm
awesome.
like, and she's just sitting there going, like, that is so cool.
That's
Um,
profound.
but the point is that it's a really cool thing. Um, requires work with a practitioner,
Yeah, yeah,
but it can be for a sick patient who's like stuck and nothing else is working. Can be super helpful.
yeah. I think
Like,
that's a big bang for buck, but
yeah,
that is clearly an investment. We do that here, by the way, which is kinda cool.
yeah. Um, so other things in the list that for long COVID we didn't mention, that's on the list here, ivermectin. That's something that we've had some pretty profound responses
Yeah,
clinically
yeah.
to. I guess it's still verboten. I guess it's still
It's
kind
I don't
it's
know.
still
I don't even know if people still
some
get their
insurances can,
feathers ruffled.
some insurances don't pay for it, some do.
Yeah, I just
It's
compound it.
yeah,
I wind up compounding it because if I do get it covered by their insurance, they're only gonna get a antiparasitic dose for 3 days and be done, or for 1
yeah,
day and be done. So if you're treating it for long COVID, it's different, and most patients are just like, "Yeah, I'll pay out of pocket, I
yeah.
don't care."
There's a lot you can probably get from Canada for a little cheaper.
Yeah. And the other
Um,
thing, peptides, again, this is taboo, but
yeah,
um, prior to the FDA outlawing certain peptides, which they're now revisiting and hopefully going to release back into the wild. As of April 15th, they released the list that they're considering, and they will go slow. It will probably only be 1 to 2 peptides per year. But that being said, and we're not claiming that any of these things cure anything or do anything other than what we've seen anecdotally, but like thymosin alpha 1 and TB4, these thymic peptides that are phenomenal for immune balancing and cell repair, MOTS for mitochondrial boosting, some of the growth hormone analogs that can help. I mean, like, there's just things that you can use that are pretty beneficial and weren't available and are going to hopefully be available
yeah.
again. Things for sleep, like DSIP, or for pineal gland resetting with epitalon, or, you know, there's just antivirals and
You've missed one very important one.
SS37, which one?
That's
A or D?
BPC
Oh,
157. I know
BPC,
it's
yeah.
like it's so obvious
It's
you
just
guys
so obvious I
volunteer,
forgot,
but
but it's just, like, everywhere now, like,
I
you can
know
get it in
it's
the
a
supplement sites, like, orally, it's fantastic,
yeah,
like, the injectable one is still outlawed, you can even do nasal for brain support. BPC is
yeah,
phenomenal, yeah,
yeah.
like, that one to me, like, isn't verboten, like, that's just kinda
It's
ubiquitous now, and everyone's already on it, so,
yeah. And then some of the things that we people will see out there,
yeah,
rapamycin,
yeah,
IVIGG,
yeah,
Maravirac. I'm not going to talk a lot about that. That's a HIV antiviral
yeah, I've not
that
used that.
I've used a few cases. It was not amazing. Truvada, which is a another HIV antiviral. Again, these are things that people see out there, but in my clinical practice, they've not been like
Yeah,
amazing. The modafinil. It's interesting because I've used that for years in my narcolepsy patients, in my shift sleep work disorder patients. And it's being used basically for fatigue. I haven't used it a lot with my long term patients because I've been able to get help with the fatigue with other things.
yeah,
But it's difficult. So the modafinil is an easy way to treat people's fatigue and daytime somnolence that a lot of specialists are using. But I feel like we have other options.
yeah,
But something people see out there. Um, IVIGG, it's listed. I have had it's near impossible to get insurance to pay for that. It's like I'm not sure what to say else besides it's near
yeah,
impossible insurance to pay for, and it's $10,000 to $15,000 a month. So
yeah.
unless you're independently wealthy, it's not going to be.
The only patients that I've ever had to get it covered were ITP patients whose platelets plummeted, and then, I know it's used in the pandas world sometimes when they fail outpatient therapies, but yeah, it's hard to get done. What about Paxlovid? Did you use that at all? I mean, maybe in the acute setting, did you use it for long COVID at all, like an extended course? Have you seen any good results with that?
Paxlovid. I've seen people acutely respond well to it. The problem is it's only 5 days, and how many people have all their viral stuff gone in 5 days?
Yeah, they don't.
So they flare at day 6 or 7, and you have to do another pack, and then the insurance doesn't pay for it.
Yeah,
I just tend to go to ivermectin. Um, it's not really available to do for long COVID because of insurance coverage. And we have so many other options that work well that don't have the Paxlovid is an older HIV drug that got repurposed. It's really funny how pharmaceutical companies can repurpose drugs, but,
We can't.
we can't, or we get yelled at for it when it's
Yeah.
common practice with them. But it has a significant amount of toxicity, so it's something I would be comfortable giving to people for months.
Yeah.
Um, but, ivermectin's had over 3 billion, doses used worldwide.
Yeah.
It's
Dirt cheap,
dirt
very
cheap,
safe.
it's safe. We have
Worst
decades.
case scenario, they get better and you diagnose parasites that you didn't know they had.
Well, okay, I had one patient.
I know this
I
case. I'm trying to provoke the story to
Okay, so
go.
one of my patients who I've worked with for years, she's awesome. She's super smart and researches a lot of her own stuff. Um, but she got COVID, and it was acute COVID, and she was having respiratory issues. I'm like, okay, yeah, I'm gonna use my ivermectin because I'm the cool, integrative guy,
Cutting edge
cutting edge guy. Gave it to her, and she started coughing up
worms,
worms.
yeah.
They started coming
Oh,
out of her nose,
rad
and her shortness of breath got horrible. Horrible. And then this little, you probably remember this from medical school, Loeffler syndrome. It's this thing where you parasitic infection in your lung and you give people anti-parasitic. If you don't stop it, they die because it's almost like the whole syphilis back in the day. You give them penicillin, they kill too much, they herx, and you could literally kill someone because it's a massive systemic inflammatory thing. Things you learn about in medical school you've never seen in real life.
Yeah.
And so I'm seeing this, I'm like, all right, thank God I remembered that weird factoid in my head. I'm like, stop it. And she stopped, and we started doing, like, a day, every other day, and so it took about 3 months before she stopped shedding,
Yeah,
but
but she got better, and no one would have diagnosed that.
it was super cool, but super like, "Wow, this stuff still
Yeah,
happens,"
yeah,
Well, I also learned from her that in, Virginia, parasites are endemic in Southwestern Virginia, just like they are in Sub-Saharan Africa. So we act like parasites aren't here.
yeah, but they are.
And this is common knowledge in the animal science world, the animal husbandry world, in the environmental medicine world. Oh yeah, Appalachia, Southwestern Virginia, parasites. And then you talk to vets, and they're like, "Oh, if you have an animal, if you'll love this one. You have pets, don't you? Oh, okay, man, we have pets. If you have a dog, cat in your house, you are being exposed to parasites." And you're like, "Well, how many of our patients have dogs or cats in
Yeah,
their
most
house?"
of them.
Yeah, I'm like, "Oh man." So all of a sudden, and it's really interesting. We're gonna have this, I won't say a name now, but a practitioner on our podcast, hopefully later on, who specializes in parasite stuff. The practice is up in New England. So coming soon for y'all listenings right now. But in her practice, what she's found out with her long COVID, Lyme, mold patients that get stuck in her population up there, that a majority of them have undiagnosed parasitic infections. And when she addresses them, all of a sudden now their immune system responds differently and start getting better.
Yeah,
So, sometimes in some patients, depending on where they live and what they do, and I'll do these little trials of like albendazole, ivermectin, mebendazole, praziquantel, and sometimes you'll see some pretty cool responses. But
yeah.
that's more like layer 7 and 8, not layer 1, 2, and 3.
Yeah, but it makes sense because if you have a parasitic infection, you're driving a Th2 mediated response, which is potentiating polarization of your immune system at the expense of Th1, yin and yang. Now you get reactivation of VVV. Now you get reactivation of another virus. Maybe you are activating a Th17 response, which, when dysregulated, leads to autoimmunity. So it's all about what's causing that shift. Is this person polarized, and what can we do about it to get it right? And sometimes you pick this stuff up. Like, I do a lot of stool testing. I don't see a lot of parasites, but sometimes I see a subtle eosinophilia, and it's just getting worse and worse and worse. And it's like, okay, maybe we need to do parasite.
Are you
Maybe
doing
do
that?
parasite cleanse.
Are you doing that one? I'm doing this one test right now. I don't want to say it on here because we have actually a lot of followers, and I don't want to overwhelm them. But it's out west where the guy looks through it by hand. Like, all of those have come back positive for parasites on my patients.
No.
Like, everybody's come back positive. I did it on myself. Every patient I've sent it, they all come back positive. It's
Interesting.
literally, and what I didn't realize is, when we send our stuff off, they put it in formalin, right? Which will dissolve chitin. Well, what's chitin? It's what's in shrimp shells, and
Yeah.
it's also in the shells of many parasites. And then before they put it in the slides, they blend it in the blender to even out so you can put it on a slide. Oh, I don't see any parasites. There's nothing there. Like, you just dissolved chitin with the formaldehyde
And
stuff,
then
and you
you
just then
blend it.
blended it. I'm like, and so he literally just takes slides by hand, does it out by hand, and does like a bunch of slides and looks at them. So he doesn't do any of that stuff, and they've all come back positive. Mine came back with still, no, shouldn't say it out loud, should I? But
Yeah.
I've treated myself. I'm okay now. But
Yeah.
but the point is, like, it's like, yeah. So it's parasites are more
That's
common.
interesting.
Yeah, yeah.
Let's
So
talk about that more off air.
yeah, I'll throw you. Sometimes we have to, people ask me questions, and I have to be careful because you know we get a lot of listeners, have a lot of and it's just we're trying to take care of our patients, and you don't want to say something, and all of a sudden your mold inspector is booked out a year
Yeah.
because everybody called them up, kind of thing.
Yeah.
Which, but
Protect our resources.
it's our goal. We want to educate people. Our primary thing that drives us is we take care of people. We want to help people that are hurting,
Yeah.
and and we got our primary focus is the people that we take care of, that we see
Yeah.
daily.
Yeah.
Having said that,
And never quit and never close up shop.
never quit. Yeah, I mean, well, how many days was our practice closed during COVID?
None.
Zero, zero.
Yeah.
We're open every day.
Yeah.
We're in ops
I
every day.
remember when we both got COVID. We came in and we gave each other IV vitamin C for 2 days in a row, and it was back to work, man.
Yeah, it's I go back to work. I was out for like 2 weeks because I got pretty bad.
Oh, that's right. I shook it off in 48
I don't know.
hours,
You're
man.
tough, mouse. Like, it got me bad. So other things, you know, low doses of omeprazole, which is an antipsychotic, other antivirals, beta blockers for a lot of the POTS symptoms,
Yeah.
propranolol. There's a whole list. I don't want to go through a whole list of things, but the point is that hopefully we give out our personal clinical list of our top
Yeah.
guns. There's probably 40, 50 more things
Yeah.
that people could try one-offs. But the point is to give people resources, to give them information, to give them hope,
Yeah.
and other things they can do. Um, ooh, hyperbaric, we forgot H-bot. I mean, that can be really, really, if you have decreased blood flow to your brain,
Yeah.
your heart, um, particularly on the front end, that can be super helpful
Yeah.
for individuals as well. We didn't mention H-bot, so
Yeah.
cool. Forgot that one. So
Hyperbaric's great. I think it's one of these modalities that kinda gets lost in the shuffle, but, that definitely needs to be in the deck.
yeah, then I actually didn't even write that one down. So good thing we're sitting here thinking. But
Yeah.
any parting thoughts for our listeners about this topic?
I just think the key is to realize that a lot of this stuff is complex, and it will continue to be, and then there'll be the new next complex thing. Just know that as integrative and functional medicine practitioners, inherently we're curious, inherently we want to learn, inherently we want to drive and move forward with the care and concern, to help patients that are suffering, to help patients that are stuck in this complex web and feel like there's not somebody out there that can care for them. And so the goal is for us to see one patient at a time and practice the medicine that we practice, but also provide this information so that if you can't come see us or a practitioner in your area that's like us, then at least you have some starting point. There's just no worse feeling than feeling stuck or hopeless, in my opinion. Like, to me, like, I'm borderline claustrophobic, and feeling boxed in is not a good feeling. And feeling, I get it. I get what it might feel like. I remember what it felt like before I discovered functional medicine, and I felt boxed in. It's almost like feeling claustrophobic every day, even though you're not in a tight space. So I just want people to keep that in mind and learn what they can and be an advocate and do their own research, and but then find help, find somebody who can guide you, right? And do the things that are necessary. You got to do the work. It's not going to be easy. Like, health is not easy to get or maintain. If you're willing to do the work, you can.
Yeah. I mean, I tell people never give up. Your body was made to self-heal and self-repair.
Yeah.
If you can just find what's blocking that process and give your body what's lacking, it'll do what it's made to do.
Yeah.
When you're 12, it's going to do a lot better when you're 70.
Yeah.
But the hope is, there are answers out there. People should never, ever, ever accept status quo and never give up. And if you don't have access, you live in the middle of who knows where. One of the reasons we do these podcasts, one of the reasons we have over 400 blogs on the website, one of the reasons why um, we have a book reading list of over 80 books on the website that I've had to like peruse over about 500 books to narrow down to, is give people like literally here's your buffet. If you're a self-driven, self-motivated person, we basically have every outlet there people could potentially use
Yeah.
because we want to see people get better.
Yeah.
And it's driven primarily by you know, first we both started as practitioners, and then for me, I adopted my daughter, and then my wife got sick, and then my family changed my direction. For you, you got sick,
Yeah.
and you got better, and you're like, "Crud, I got family," and you fixed your family, and now you're like, you know,
Yeah.
we that's our primary driver is that, and that's what keeps us going,
Yeah.
is,
No going back, man.
can't go back, man. It's like with, Alice in Wonderland. Once you see the worlds, you go from black and white to color.
Yeah.
You just can't go back.
No.
You can't go back.
I always talk about Oz, like, Oz pulled me behind the curtain, so
I'm
this is how it
sure,
really works. Yeah,
and you're
so,
like,
yeah, I'm not going back, and I think that this is one of these things that you and I both realize we were meant to do, and I just want more people to have access to it, so that's why we do these things.
yeah, and we have a lot of practitioners who listen to our podcast, um, and actually, reach out to us and say, "Hey, if you're looking for someone to come join you, send me an email." So it's really interesting how impactful this has been for patients and practitioners and just educating people. That's what we wanna do. We wanna change that, so
Yeah, awesome.
cool.
I'm excited to see what people write about what they wanna hear, about what they want us to talk about next. I'm excited to see.
Well, actually, one of the things that I'm gonna be talking about, on the little 10-minute things we do on Friday is actually, traumatic brain injuries. Someone actually reached out saying, "Hey, could I mention it here and there?" We talk about sort of,
Yeah,
but never actually done anything dedicated, because that's a small snippet that I
yeah,
feel like I've gotten pretty good at.
yeah,
That
awesome.
how often do people get concussions?
Yeah,
All the time.
yeah,
You played soccer.
yeah,
How many times did you get concussions?
yeah.
A lot.
Diagnosed?
Well, that
0.
well, there's a reason why the
Anecdotally, many.
well, there's a reason why they said kids can't hit the ball anymore if
Yeah,
they're less than 12,
yeah.
because all these kids being micro concussions.
Yeah, my son is 10 and he just made travel, they still can't head the ball.
Yeah, but then I thought it was 12 in Virginia or
Yeah,
something like.
he can't head until he's 12.
Yeah. Now some people complain they can't compete against Europeans and South Americans because 'cause they're heading it
No,
when
we
they're
do
like,
headers at home, he just doesn't do it as
s
practice. I got European roots, man.
yeah,
He's got a
European,
hard Polish head, we don't have to worry about it.
like, his carpet his skull's extra thick,
Yeah,
so
we have extra thick
but
skulls.
that's one of the things that hopefully I'll be doing here when I get spare time, but if people would please let us know if there's things you'd be like us to talk about in longer
Yeah,
form.
or just tell us your story, like, I
Yeah,
just wanna hear what you all think and what you guys, are going through and what you want us to talk about. We're happy to do so.
yeah,
Cool.
excellent. Well, y'all take
Alright,
care, and we'll
man.
talk to you soon.
Talk to you soon.